Okay, and it looks like we're now live, and let's stick with our tradition of trying to start right on time so we have as much time as possible to get to the meat of it. Welcome back to all those who are attending again to our Analytics and Palliative Care Journal Club, and welcome to the first-time attendees on behalf of this fantastic panel of organizers. We appreciate you taking the time to talk about what I think is going to be a really interesting set of issues. The topic today is Lessons in Complexity with Camden Coalition founder, Dr. Jeffrey Brenner. And let's get right to setup. Just quick reminder, use your Q&A. There's a Q&A button if you have questions, and we'll, as always, do our best to answer as many as we can. And we are recording. This recording will be posted to the Cyft website, and you'll receive notification when the podcast and video versions are ready. So let's get into it. Many of you may remember in 2011 when Dr. Atul Gawande wrote an article called The Hotspotters, and in it he introduced us to Dr. Jeffrey Brenner and the Camden Coalition. Notable about that article were the amazing results that this program was achieving. 56% reduction in hospital costs, a 38% reduction in admissions, and I think appropriately so, Dr. Gawande referred to this as almost certainly revolutionary. Well, this article really launched an enormous amount of publicity for the Camden Coalition, and within a short amount of time, the Camden Coalition was picked up for a Frontline special. Scientific American was writing about them. Robert Wood Johnson was writing about them. Dr. Brenner received a MacArthur Genius Award, a $14 million CMMI-funded program to deploy this program across 4 different states. Really, headlines were referring to this as having finally cracked the seemingly impossible nut of keeping the sickest of the sick, sometimes referred to as super utilizers, healthy, reducing cost, improving quality. I think that this particular program, beyond any other, at least in the last decade, has really shaped the way we think about high-intensity care design or care management. And in reflecting back, even a lot of the terms that we take for granted when we're designing care management programs now, hotspotting, or this idea of using data to find the highest utilizers, moving beyond the clinic into the community, interdisciplinary care teams that focus on more than just your clinical conditions. Social determinants of health has become such an important topic and such a buzzword. Care navigation, the idea of connecting people back to the complex system of healthcare. Of course, many of these concepts may have existed. There's really no question that they've become much more popular and have become really the foundation for how we think about care management as a result of Dr. Brenner and the Camden Coalition's work. In January of 2020, Dr. Amy Finkelstein published the results in the New England Journal of Medicine with her colleagues from MIT. This is a several years long randomized controlled trial aimed at answering the question, what kind of impact does the Camden Coalition really have? And I think it was surprising to many when the results of that article showed, in effect, a negative result. And I quote, the 180-day readmission rate was 62.3% in the intervention group and 61.7% in the control group. In other words, the intervention as designed did not have an impact on reducing readmissions, which was the primary outcome, which was is really the harbinger of whether or not patients are being successfully managed and whether or not unnecessary utilization is being held down. So this is a story of a negative result and a really important one at that. But the more I learned about the Camden Coalition, the research that had been done, and speaking with Dr. Brenner and others, the more it really struck me that this is an incredibly important topic for us to focus on, not because the population was exactly what we are used to in the palliative care community. I wouldn't want anyone to be of the impression that this is apples to apples, but because this is a story, most importantly, about compassion and dedication to the populations that need our help the most. And I've really grown such an admiration for what the team of people at the Camden Coalition have done and attempted to do. Number two, it is a story complete with so many lessons related to data science and evidence. And it really causes one to stop and think about the way we invest in and the way we measure the impact of programs. And I think there's a lot to learn there. And finally, for me, most importantly, this is a story of integrity. This is a story of a group of people that really didn't need to continue to study and seek out truth. They had the resources, they had the momentum, they had the credibility, and yet they continued to try to find ways to improve by using randomization, the gold standard of evidence generation, to understand the type of impact their program was having. And when they got the negative results, they published them. And even further, Dr. Jeff Brenner is here to talk to us about what he has learned. And Jeff, I have so much admiration, respect. It's such an honor to be able to speak with you and introduce you to this wonderful group of people that similarly is dedicating their career and limited time on this planet to caring for those most in need. So with that, allow me to introduce, and I'm going to hide slides, and we're going to talk with Dr. Jeff Brenner.
Great,
Jeff, can you hear me all right? You're great, all right.
Yep, sure can. Thank you, Len. Thanks for the invitation and the chance to speak with all of you.
No, the pleasure is ours. And I thought what we would do, this is a journal club and we will talk about the details of the study, but why not take advantage of the fact that you're here to have you introduce the Camden Coalition and the original program design. What did it set out to do and for whom? And we'll use that as the start of the explanation of the intervention, and then we'll roll into the study itself.
Sure. So it started about 16 years ago, and at that time I was a solo practice urban family medicine doc, seeing kids, adults, and delivering babies in my little office, and pretty frustrated with the stack of paperwork coming from the Medicaid HMOs asking me to fill out all this care management stuff. And you sort of stack up all the paperwork and say, what are these people doing? Like, why are they asking me for all this? Why don't they do this? You know, what do all these people do? And then when I'd call the care managers and I'd say, look, can you go follow up on this? They never did anything. And so incredibly frustrating. We started a breakfast group of local primary care providers and did that for a couple of years. And there was just a huge demand. There were all of these community-based providers still out there. And we started to get together. That at the same time, I was working with a medical student doing a summer project on the rates of violence. And we started to collect emergency room data on assaults and injuries coming to the emergency room, which turned out to be a much higher and more accurate count of the assault rate across the community. So we took all of this claims data from the local hospitals, and we took this disgruntled group of people having breakfast and formed it into the Camden Coalition, very much targeted with the idea that we could do it better than the Medicaid HMOs, that all of this gobbledygook about telephonic case management wasn't working, and that we could roll up our sleeves and do a better job.
And the intervention, we'll spend a couple minutes talking about the details of, but basically you would identify folks upon admission and then surround them with a multidisciplinary care team, follow up, home visit within a certain amount of time, attempts to connect them back into the system. I think you had described it to me in the past as a care navigation program that had with it a certain degree of social supports. Is that a fair?
Yeah, one piece to add is we had started and we're running the Regional Health Information Exchange. So we had real-time data feeds coming through from the 3 local hospitals, all the ADT feeds. So that was the source of the data. We would deploy staff and we had badges to all the local hospitals, and we could go right to the bedside. So that's fairly unique in that we could move in and out of all the local hospitals with multiple badges to each hospital and go right to the bedside and enroll people based on that real-time data feed.
And then the second question I had for you before we talk about this study, and all this is about before that study, the RCT occurred, is how did the randomized controlled trial with Dr. Finkelstein's team come to be? Because there were studies. There was a small sample size study of something like 36 patients, which showed a tremendous cost savings and reduction. And then there was that 4-state observational study, which also showed a reduction. And it too was observational and after the fact. How did the RCT idea come to be?
I was introduced to Amy through a colleague who is a journalist that had written about her work previously. And all of my career, I've been a huge fan, believer, and advocate for evidence-based medicine, and really feel like the field of population health at that time, and frankly still, doesn't have a lot of integrity. There were tremendous claims made by particularly the for-profit sector about how different programs save money and work, and I find it incredibly frustrating to see money pulled out of the health system for things that don't work. As folks probably know, a lot of the claims about employer-based wellness programs are very flawed, not based on RCT evidence, and a lot of the claims about care management as well. So really felt like we needed to bring integrity to the field.
That's fantastic. So what we'll try to do now is hop over to the slides again and spend a little bit of time talking about the randomized controlled trial itself. Let's see. Okay, so the study background, it is a randomized controlled trial. The intervention was designed to test this intervention, which was, and I know that I'm abstracting a bit, but it's hotspotting, the idea of using data to identify folks that are the highest utilizers or the most in need. So they had an algorithm, and then they surrounded folks with the greatest need with a care navigation team, interdisciplinary in nature. And Dr. Finkelstein states right in the beginning of the study, the reason to conduct this study was to really try to avoid this phenomenon of regression to the mean. And the way they did that was with a control group and, of course, randomization. So you attempt to identify both a control group, folks that do not get the intervention, and a case group, folks that do get the intervention, and you do your best in advance of randomizing to make sure that they look and feel as close to the same population as possible, so that the only difference between those who get the treatment and those that do not is the introduction of randomization. Quick recap on regression to the mean. We had talked about this at a prior study. The reason why it's so important to attempt to have a control group and to avoid regression to the mean is when you use the same group and you recruit them at the absolute height of their acuity or utilization, and then you measure them some 3 or 6 months later, there is a natural regression downward of that population. And a major flaw in many of the published studies that attempt to measure the impact of care management or care programs is that too often they identify a group of people that are at their sickest and then measure that same group sometime later. And randomization is a method designed to eliminate that potential bias. The inclusion criteria, and again, this gets back to how these were pretty sick folks, 2 or more admissions within 6 months, 2 or more chronic conditions, and then 2 or more of the following. You must have had 5 or more active medications, difficulty accessing services, a lack of social support, a mental health condition, an active drug habit, or homelessness. And if you think about that, oftentimes in studies of palliative care, there are exclusions of folks that have active drug habits, mental health conditions, and homelessness. So this should tell you something about the nature of this population served, and should cause us to think about whether or not we should be including or excluding those folks in our studies. About the population, 95%, and this is after they recruited, then this is their table 1. They looked at the folks that they had recruited, and 95% were unemployed, 40% are younger than 55 years old, 40% on the time that they were admitted had a diagnosis of substance abuse, and 30% had a diagnosis of depression on the time that they were admitted. All good studies should have this sort of flow chart to help you understand the number of patients they began with, and then ultimately how many they ended up enrolling and how many were directed to the case group or control group via randomization. They launched this study with 393 cases, 389 controls. 2 quick questions for you, Jeff, if you don't mind. Number 1, how long ballpark did it take to actually recruit that many folks? And number 2, could you speak a little bit about this concept, randomizing right at the point of care, which is a challenge, but important for these types of studies?
Yeah. So you can randomize at the data level or randomize at the point of care. If you randomize at the data level and then you can't find the patient, that means you end up being assigned people into your group who never received the intervention. So the gold standard for these models is to really go to the bedside and randomize people. That's how Mary Naylor had done her randomization. That's really hard to do. So if you can imagine, you've got a very talented, warm, caring human being that walks into a room with a very disabled, perhaps, patient with addiction and a lot of complexity, talks them into enrolling in the intervention, and then walks out and randomizes them, and then walks back in and tells them whether they're part of the intervention and control. So I'm certain lots of you have run trials. It's really hard, putting people into a control group, particularly when the staff are selling the intervention and feel like it does help people. Len, I'm sorry, what was the second question?
The second question was also related to the execution of the study. Was how long did it take to achieve nearly 400 cases and 400 controls?
It was painful. It took about 3 years or so, 3.5 years. And I mean, we had a CMMI grant, so it paid for the core staff, but there's a lot of staff around an intervention that you need. And, we were sort of borrowing, stealing, and grabbing every source of dollars over and over to keep this thing going. And then needed to keep it going even after we walked off the CMMI grant in order to keep collecting the data. So, unfortunately, there's just not a lot of robust funding. There's a lot of funding for one more test of a meaningful Me Too hypertension drug tested against another meaningless, Me Too hypertension drug, but not a lot for robust population health trials that take time.
Thank you, Jeff. So now let's talk about the intervention. The intervention itself begins in the hospital, and this is referred to as the index admission. Upon being successfully enrolled to the case group, of course, or the intervention group, then a multidisciplinary care team is assigned, and their job is coordination of primarily healthcare-related services, though it also becomes clear when you speak with the team and research the work being done by Camden that there was no short amount of social support as well, and of course coaching. The median intervention length, so the amount of time you're in the program, 91.5 days. The control group, or the folks that didn't get the intervention, received, quote, usual care. And I think the study does a good job of making clear that that can include home visits, care management, follow-up, et cetera. The study team was not able to collect that data, but I think suffice it to say the amount of care, additional support delivered by the Camden Coalition as compared to, quote, usual care was likely substantial, and Jeff can add some color to that in a bit if he thinks it's helpful to do so. The outcomes that were measured, the primary outcome, and talking to Jeff about this, I think the great thing about a well-designed randomized controlled trial is it's almost, the cleaner, the better. And I think that allows us to get through the study section of this pretty quickly. But they use traditional logistic regression, a pretty straightforward statistic to understand the difference between the case group and the control group. And the primary outcome was readmission within 180 days. The secondary outcomes include the number of readmissions, percentage of folks with 2 or more admits, hospital days, hospital charges, payments received, mortality. I would like to make note of the fact that Dr. Finkelstein and team may still be analyzing many of the secondary outcomes, and more studies may come, but this study was focused on publishing the results of the primary outcome, which is readmission. The data that they received was based on discharge data, except in the case of measuring some of the secondary outcomes, they had they had to get additional data sources to understand, for example, whether or not social services were delivered or whether or not folks died during the study. And here are the results. Basically, no measurable difference between the case group and the control group. I thought an interesting thing that they did, they said from the beginning the reason to use randomization is to better understand the impact as compared to using a pre-post study, which is subject to regression to the mean. They did take the time to measure the pre-post in the control group. In other words, just measure that group when they were enrolled and then some amount of time later. And just as expected, they saw a 38% decline, which is exactly the decline shown in the original pre-post study and 1 point off the decline shown in the 4-state observational study that was conducted as part of the CMMI grant, which is just a fantastic inclusion and sort of drives the point home, in my opinion. Then in the discussion, Dr. Finkelstein and team make clear that this may suggest, first, I think it argues strongly for finding ways to make randomization better, faster, cheaper, and a necessary inclusion in the study of care management programs. But also they draw attention to what becomes pretty obvious. There may be real challenges in trying to reduce utilization, readmissions within this highly complex population. And I think they also gave a nod, and Jeff had explained this as well. The Camden Coalition has done a lot to evolve the model over the years, and we'll leave that for part of the discussion, but I do think it was interesting that Dr. Finkelstein and team gave a nod to the fact that they were measuring, as all studies are forced to do, they were measuring as best they could a fixed intervention, but that intervention has evolved significantly over time. That concludes the formal review of the study, the informal formal review of the study. I would invite folks, of course, just a quick reminder, send your questions to the Q&A because now we start to get to those, starting, of course, with our esteemed panel. But I have to take this opportunity to ask one question before the panel kicks it off, which is, can you please walk us through the reaction of the team on the day that Dr. Finkelstein revealed to you that this program wasn't achieving the impact you had hoped for?
So there were really two different groups. There was the sort of inside group, meaning my core data team. And we looked at because we knew the two groups and we had real-time data coming through the HIE. Even halfway through, we knew some of the results, so we were not that surprised. Also, clinically, we had done a ton of work with what we called non-responders, so the core data team was not that surprised. We had obviously kept it very quiet, so the broader organization was quite surprised, and you know, this stuff is very upsetting. You know, it can destroy an organization. You know, our core feeling was that science is a long process and that you succeed by failing. And, you know, we all know many, many great findings in clinical medicine were preceded by a lot of learning and a lot of negative results. So, you know, that's easy to articulate, but much harder for you know, a big group of people out beating the pavement and taking care of patients who anecdotally look at people and say, but this patient got better, and that patient got better, and that patient got better. What they don't see is the equal number of people that didn't get better because they're invisible. They fell out of the model.
Thank you. I appreciate you walking through that. I can imagine that was a challenging time. And again, so much credit to you and the team for deciding to study it and sharing the results. So then let's begin in the exercise of learning as much as we can in our limited time from you. And I want to invite Amy, Caitlin, Martha, Janet, Dana to please pose your questions and to start integrating in the questions from the folks that have joined in remotely.
You know, I think the central question that comes to mind, and I so appreciate what you said about failing, that like Thomas Edison would say, that he didn't fail, he just created a lot of light bulbs that didn't work. And it's only when we try these things to see, but why do you suppose, why were they still utilizing is the question that comes to mind. Are we imposing a medical model on a social issue that isn't well addressed by a medical model? So why do they still utilize?
So great question, and that's the most important question. If you think about back at that time, you know, we started this almost, you know, I don't know, 10 years ago now, 8 years ago, and the dominant feeling at that time was that healthcare is disorganized and that there were all these efforts to untangle healthcare and make it easier for people to use and navigate them through. And the assumption was if we untangled it, that it would have an impact on people. And all of us as clinicians can think of examples where we personally got involved and actually navigated someone and they got better. So I think we had some plausibility that, there's lots of other problems, but if we navigated, we could make an impact. And I think we all felt like telephonic case management, I can't think of a reason why that would work, but that in-person case management would work. That if you went with people to their appointments, got deeply engaged with them, went to their house, went to their shelter. I think what we pretty quickly found out was that we were navigating people to nowhere, that these were some of the sickest patients. Like I had 2 or 3 of these kind of patients in my own practice. We now had, hundreds of them. Like we had done an incredibly good job of finding the most addicted, most mentally ill, most complex people. And then when we navigated them to the shelter, navigated them to the Board of Social Services, navigated them to behavioral health and addiction, we actually went with them to their appointments. And many, many, many nights I sat with my staff who had been all day at the Board of Social Services, all day at a behavioral health entity, telling horrific stories about how these patients had been treated. So it suddenly became a root cause analysis of like tragic behavior by frontline staff in all of these organizations. So, we were navigating people to nowhere. Another good example of that is we began to look at what we call non-responders, and we needed to come up with different language for patients who were not responding to the intervention. We often call them non-compliant, like all these words that I don't think really reflect the clinical mechanism of what's going on. So we started to do a lot of secondary analysis on who was not responding to the intervention. One of the biggest findings is we got jail data, matched it into the HIE data, and looked at that as a predictor, and it was incredibly predictive. If you'd been to jail, your likelihood of completing the intervention, following up, or having improvement in your readmissions plummeted. Another good example were people with significant mental health admissions, significant addiction admissions. So we began to identify all of these different subsegments that were essentially non-responders to the intervention.
So Jeff, as a follow-up to that, in your subgroup analysis, did you find a group that statistically performed well? And can you talk about that group? And was there a particular part of the intervention that you felt like worked? Was it really like patient dependent, or was there something that you could share with us that, hey, this piece worked on the majority of folks?
Yeah, so if you were not addicted, not mentally ill, and not in jail, which you saw the age distribution, so you understand who these folks are. If you are older, slower, meaning you're not moving around as much, and it's predominantly medical, so like really connecting you to a primary care provider, going with you, making sure you got your refills, those folks got better as far as we can see. Now you start getting into like smaller and smaller and smaller subgroups, and we were really careful in the study. We submitted the study design ahead of time. So, you're not supposed to change your study design. You're not supposed to do after the fact analyses. So there will be some follow-up studies that come out. But those are really meant to be hypothesis generating for future studies, not to analyze the data and get to smaller and smaller subgroups.
So the take-home point that I get from that is maybe the population that we often take care of. Certainly we have mental illness and substance abuse, but we have a lot of elderly people. They might actually do very well with this intervention.
Yes. I think that's a core group it's really primarily medical. The other thing that just jumped off the page to us was the level of trauma in the population. And it's something I understood a little bit about, certainly in practice. I mean, frontline family doc, but we had done a pretty deep interview of a whole lot of our patients, and it just jumped off the page over and over and over and over. And it led us all to read much deeper in the trauma literature. And it's much more common on the medical side to understand this literature now. Back then it was not. And, I would argue that the patients that fail out of all of our interventions, including palliative care, have much, much higher rates of trauma, which are predictive of poorly treated mental illness, poorly treated addiction, non-compliance, all of these other variables. It's a poorly understood variable in all of this kind of work.
Jeff, you spoke about the tremendous interest in finding another Me Too drug, and we've certainly seen this fascination with shiny objects and wearables and sensors and these sort of sexy toys that are fun to study, and very little interest in these very complex, robust population health studies that, as you saw, took 3.5 years to enroll and study 800 patients. How do you think about influencing and changing that so that we do get more really important results like this study?
First, it's important to understand the economics behind that. So a lot of these apps and gadgets and other things, they have high fixed cost and low variable cost. And if you don't understand those terms, you absolutely should spend some time understanding them. What that means is that it costs a bunch of money to make an app or to make some software or to make an algorithm. And then every person you sell the algorithm to, it costs almost nothing. So that means that anything that is tech-based is incredibly profitable. The multiples off of that are huge. Human being interventions, though, have very high variable cost, meaning that you have to creep in, and you keep having to hire staff linearly to the enrollment of additional patients in the intervention. Primary care has the same problem. You just can't make the same multiples of profit you would make off of that. So as a result, everyone wants to figure out like a gizmo or a gadget because you can make incredible profit off of that. You'll never really make any money off of care management interventions. The multiples will never be anything like Apple and Microsoft and tech companies make off of IT gadgets. And we're going to keep having this problem until we, this is a little bit like the 1950s where drug companies sold drugs that clearly didn't work and harmed people, and lots of interventions harmed people. And, the FDA tightened down the screws and required high quality research in order to release a drug. They're going to have to come a time, I think, when, more and more of these public claims are tested rigorously, because they could just as easily be hurting people. We are wasting a lot of money still to this day by by nurses in cubicles calling people not responding. Just billions of dollars are being spent. There are state requirements and state contracts all over the country requiring, specific ratios and like, what is a phone call once a month going to do to a complex Medicaid patient? That's still going on right now. Lots of money. And it's being pulled out of the delivery system where that's just unjustified.
A great point. And I think a lot of us are sort of wondering more about the intervention and how you came to the 90-day, design, and wondering, telephonic is not enough. Maybe 90 days wasn't enough. What were those conversations like when you were designing the intervention, and might the results have been different if the team had intervened longer and there had been funding to do so and so forth?
I don't think navigation in the end was going to work. I think the question is, to what end are you navigating? Where are you helping people go? And I think we need to spend a lot more time about talking about care delivery and be very systematic. So let's take an example. We know that Suboxone is in many orders of magnitude. I mean, it's more effective than AZT. It's just incredible. And yet many, many patients who need it aren't getting it. So there's a huge gap between the evidence base and the delivery out there. Another good example are IM antipsychotics, incredibly effective, many patients still not getting them. And navigation alone is not going to solve that, because when you actually pull the lid off the delivery system, you have many psychiatry offices that don't want to give people shots. You've got many frontline providers and huge waiting lists for Suboxone. So, we found in Camden, there was tons of services that were not evidence-based. Another good example is for homelessness, Housing First is just as powerful as Suboxone. It's incredible. If you get a patient into a Housing First unit, which is complicated, takes skill, in many communities it's not available, it's incredibly effective. mortality rates plummet, utilization plummets. If you put them in a homeless shelter, they fail out. And homeless shelters are expensive, they don't work, they're not evidence-based. So, you know, we've come a long way. You know, geriatrics is really, I think, where we've made a lot of headway early on in randomized controlled evidence for things that improve outcomes, improve mortality, and lower cost. And I think we've been spending a lot of time to get more and more fidelity at the delivery side and at the coordination side in that space. And it's paying off. You know, care of underserved populations, we're so far behind. We have a growing evidence base, but we're not delivering any of that with fidelity. What I'm very excited about are things called ambulatory ICUs, which are essentially a physical location where a patient is going to be able to get their primary care, their behavioral health, and their addiction all in one location. It looks a lot like a Ryan White clinic or a PACE program. You know, we have glimmers out there in healthcare of what true complex multidisciplinary care looks like. Palliative care is a good example. But, you know, we have not figured out how to stably fund those things. We haven't figured out how to stably test them and how to stably scale those either.
Jeff, I'm going to read a question. Were patients assigned to control groups only if they affirmed that they would enroll in the program? And I want to add one of my questions to that is that when you went back and looked at the differences between the two groups, was there anything that stood out? Was one sicker than the other? So very similar. Okay.
Yep. The randomization worked. Ended up with the equal groups. It was a big enough N to randomize the noise.
So the answer to that question the person asked was, were they assigned to the control group only after they agreed to participate in the study? I would imagine the answer would be yes.
Yes.
Okay.
Jeff, there are a number of questions in the chat about the measure of 180 days, and maybe that's not the right measure for this group. Would you comment on that?
I think it is the right measure. I mean, we pretty quickly pivoted in Camden towards starting and running our own Housing First program, which was like the most painful strategic decision we made as an organization. I mean, getting into housing is a pretty steep thing, raising money for that. And we saw immediate differences. You'd move people in and like they do better within a week, 2 weeks. Saw the same thing in the work at United I did in follow-up. Same with Suboxone. You get people on Suboxone and you wrap really high quality harm reduction, trauma-informed addiction treatment around them. They just stop going. So same with IM antipsychotics. Like they're acutely psychotic, they keep getting readmitted. If someone will finally, the hospitals won't give them, they give them like 10 pills and they leave and they don't get the prescription filled. Right. It's like the craziest stuff. Like when you do that, literally within a day, they respond. Or actually within 5 days, they respond. Mm-hmm. So I think the time measure is right. I think this really comes down to applying the micro evidence to a macro problem. There's many little nuggets of evidence, you know, and the same with palliative care. You guys have developed a micro evidence base that ladders up to an overall intervention called palliative care.
Can I push on that, Jeff? Because I hear a recurrent theme related to, and this is just a data science perspective, but substratification. The same approach used by Amazon to move us away from just saying you're all consumers to trying to understand the very specific things that you're likely to buy based on your data. And I'm hearing you hint at rehabilitation programs may be appropriate for this group, housing for that group. So is that the theme? Is that the future, to move away from you are very sick, therefore you get this treatment, towards something that looks like you have this very specific need and we have a very specific intervention for that?
So if one outcome of this call could be to stomp out risk stratification, I would be incredibly happy. You know, we sell all these dumb algorithms out there, and as though you could attach a single number to a patient that would tell you everything you need to know about them. And that would be like attaching a number to you and figuring out like what car to sell you. Like, you know, advertisers stopped doing that like 100 years ago. Now they segment to you by a whole variety of complex demographic, psychographic data points. And then, when you go to the store and you go to the rack and you pull that sweater off the rack and it's the size that you want and the color you want, that's not magic like fairy dust. That's not good luck that they happen to have one last, of your size. That's amazing data science behind that, so that the entire supply chain, starting with someone sewing in a third world country all the way to that rack, got you the color, the size that you wanted. And that's segmentation. So we're going to have to do the same thing. And as you get higher and higher in utilization and higher in cost, you have tremendous complexity. And the way to deal with complexity is a multivariate segmentation model, so that you put people into meaningful groups, define them in a way that's meaningful, and then build interventions around them. And that's a really sort of messy, nonlinear process that's hard to do. It requires lots of kind of trial and error. What you do need to do within that segment is have stratification. So you segment first into meaningful buckets, and then within a bucket, you've got to figure out, where do you start? Who's the first person, the second person, the third person you work with? And that's where stratification comes in. So, risk scoring should be a second order function. The first order should be, what are the meaningful segments? And now we're getting in, medicine has essentially been that. Originally there was like stomach pain and bleeding. And then way down the road, we came up with all of the different drivers of that. And we slowly began to realize that, like, gee, people with this amazing bacteria, H. pylori, if we treated that, it could get better. We're back at like the early days of medicine and bloodletting in our understanding of care management, in our understanding of complex populations, and our understanding of what to do about them. And, if you look back, a lot of that had to do with better and better terms and words and diagnoses. Like way back, we were talking about humors, and we knew people were swollen and had fluid. And then we got like way more subtle about what that is. So shortness of breath, and we got an understanding it'd be your heart, your lungs, your blood, and then further segmentation of like what all the physiology and anatomy and biology of that. We've got a long way to go in what's the terminology and segmentation frameworks around trauma, around addiction, around behavioral health, around medical care. How do all these things overlap? What are the meaningful and coherent segments? And then what are the evidence-based models? This is a project of the next 50 years. And I think our job is to set the next generation up and, help them along the way so they don't do as many stupid things as historically we've done in healthcare.
Jeff, along those lines, do you wish that there were different outcome measures that you would have included as part of this?
So, we had so much discussion about that, and we actually measured a lot of things, but when anyone who's ever done a study, at some point you have to call the ball. And RCTs are so much better when they're simpler, because then you get to the end of the study and you actually collected all the data and the data's not missing. And I wanted to get to the end, and whatever we called, we did. And we didn't have to report like all this missing data at the end. So we collected lots of other data. There will be follow-up studies, and there have been, but I thought it was really important. And, I'm a family doc, so obviously the qualitative measures of patient outcomes are really important, but let's all be honest, no one gives a shit if it didn't save money and lower utilization. Like, that's the macro variable that we need to hold ourselves to. I still think it's the right variable. I still think that when a patient goes to the hospital 100 times, that is such a failure. We should be so embarrassed by that. And it should never, ever happen again. Like, it's, that's the equivalent of like cutting the wrong arm or leg off. It's a never event. Like, literally, if I were Medicare, I'd never pay for more than 10 admissions. Like, it just should never occur. Something has gone deeply wrong. Like, find me a single outlier that's not a failure story. Like, these are all failure stories. So I want to, I want to hold us to that in some ways, but I don't want to not work on the other qualitative things. They're super important, like, self-reported well-being. All of those things are important. I guarantee, though, if you keep a patient out of the hospital, all the other qualitative metrics are going to get better. Like, something's gone right. because it's never like a good place to be. They're mean to you, they hurt you, you get super infected, like all kinds of bad stuff happens when you're in the hospital.
So how have you adapted your model since this time, especially in those hard to treat populations? What have you learned? What can you
so about halfway through the study, we got, we gotten all this data from the police department. So after I left, the Camden Coalition built a really cool intervention partnering with the police department. There are other models around the country that are quite similar, sort of embedding social interventions together with the police department. The other piece of this is I took a second job and teamed up with a woman who's on the call today, Kathy Stillo, and got invited by the local hospital to take over their urban Medicaid clinic. So this is a big teaching hospital with about 40,000 visits a year. And as part of that work, we started an addiction program. And it's still going today. Actually, the addiction program is bigger than the primary care clinic, and both going very successfully. So, that was a recognition that if this was, the teaching clinic was where a lot of the sickest patients go after their admission, and they're often seen by residents. And our feeling was it wasn't going well, and it needed a re-snap. We made a lot of progress in that. And then the addiction services in Camden were terrible. And no one was prescribing Suboxone. We came a long way in that. Actually, there was one FQHC prescribing it, but overall very small numbers compared to the size of the problem. So that was a big pivot. We also launched a Housing First program and got deep into providing housing, which was frightening for the organization, frightening for our board. And then when I went on to my work at United, that was the most critical piece that we took forward, which is we used funding at United Healthcare to pay for up to a year of housing for patients that were United Healthcare outliers, and had, I think, good internal data once we took out the regression of the mean, that 40% regression of the mean, to show that we were getting about a 10% to 20% bump from it. Once again, like we need to do an RCT. It was just not possible in that environment to do an RCT, but there have been some fledgling RCT efforts in Housing First, and early data that looks positive.
Jeff, if you were to extrapolate lessons learned from your Medicaid, younger substance abuse challenged population to the care for the frail and the elderly, as so many of these new value-based contracts are being deployed, which for the first time ask palliative organizations to, they will reimburse palliative care organizations to go out in the field and to do community-based care in ways that hadn't been reimbursed in the past. And with that will be an onslaught of evaluation of such efforts. So what lessons from a clinical side and from a method side would you hope can be learned from your experience for the palliative community?
I think we need better terms. So I don't like the word impactable. Like, can you imagine us saying, ma'am, you've got stage 4 colon cancer. You're not impactable. We're going to go on to the next person. It's a terrible word. And it also robs us of curiosity. Like, once you say someone's not impactable, you're like, well, fuck it. Like, what am I going to do about it? So I like the word responder, non-responder, because it leaves a lot of curiosity. I have no idea why they're not responding. It could be our treatment, or it could be, so there could be a mismatch between the treatment we're providing and the typology of that patient, or it could be that patient's not ready to change. We don't know. So I just like the word a lot better, kind of responder and non-responder. I just think it leaves a lot more curiosity about what's going on. So I think there's like this 4 box of people who regress to the mean spontaneously, and people who are enduring utilizers. There's probably a third group of people who cycle. And then the other part of the axis would be responders and non-responders. And they each need a different intervention. So people who are spontaneously going to improve should never have started utilizing in the first place. Now, if they're a one and done, we probably would never find them. But if they're like, 10 visits and then they stop going, it should have been 2 visits or 3 visits. And then people who are persistent outliers, that's unacceptable as well. But they're different people. They have different drivers. They've got different things going on. We need to use these variables as indicators of what's occurring. One of the things I see with staff is that they will spend a whole lot of time with people who are not ready to change, and then not any time with people who are ready to change. There's a tremendous mismatch between staff effort and targeted at the right patient. And you'll look and you'll be like, my God, you visited this person like 17 times in the last 2 weeks. They're not getting any better. So I think what you find, you hire these incredibly idealistic people out in the front line, and they misallocate their time. And they don't even have a language. They don't know how to, it's like giving up. I'm not going to give up on this person. Well, once you rearm them with some different words, you're like, well, they're not responding. Why don't we come back to them? We're going to put them in our non-responder group and enroll them in our non-responder program. And then we're going to come back to them. Maybe it's a month, maybe 2 months, maybe 6 months. I just think we need to start to give our staff a different language so that they're not feeling like they're giving up on people. And think about how, as quickly as possible, we recognize when someone's not responding. And a lot of that is daily case management or daily case conferencing. They've got to bring these hard cases, and you've got to relieve them of the guilt that they're setting that case aside, and they're going to come back to them at another point. The other piece is the staff need a lot of training in trauma. Like, all of the things that we're taught are counterintuitive to how traumatized people respond. So, people who've had a lot of trauma have had authority figures hurt them, and we're authority figures. And we say all kinds of things that are triggers for them that sound a whole lot like all the things that were said to them when they were younger, and have had abuse, physical and sexual abuse, from authority figures. We do that and don't even realize it. Our staff do it and don't even realize it. So part of the healing of someone who's had trauma is to give them locus of control. And that's really uncomfortable because we're used to having some sense of control as providers. So I think this is a really deep challenge of how we train people in trauma-informed care, harm reduction, motivational interviewing. I think positive psychology has a lot to offer us in how we can think about these things. We created a training program that are half-an-hour videos that are available on the Optum website. They have CME, CEUs, they're free of charge. There are about 20 videos that are like clinical nuggets. They're very easy to digest, and they're best done as a group. So you round up 10 of your staff, you watch the video, and then there's a half-an-hour discussion guide afterwards where you kind of pull the content of the video apart and talk about it. Our staff will not absorb any of this training if they don't do it as a group. They've got to bounce it off each other and kind of talk about the concepts. A lot of our staff have had trauma in their own life. People who were drawn to healthcare have had addiction, have had mental health issues in their family, and may not even be consciously aware of that, and can really harm patients and do disservice to them if they don't become conscious of some of the natural tendencies. You'll see people go to two extremes in a clinical meeting. One group wants to take them home and adopt them, and the other group wants to fire them. And literally, the whole meeting will fall apart over that conflict. That's a classic trauma-informed problem. And there's lots of training and words and terms and ways to pull that apart and think about that.
And there are understandably so, some requests that we send that link out to folks. And it also just reminds me of the fact that we are receiving far more questions than we can answer in our time. And I just want to tell everyone we're doing our best to get to the questions, and we're trying to pose questions that summarize many questions. One I will pose, and I want to open this one up, not just to you, Jeff, but really to Dana, Martha, and others that are sitting in these sort of government sponsored and designed efforts to evaluate primary care programs. Do you have thoughts about the methodological implications when you're sitting in these study reviews or proposal reviews, or you're sitting on a CMMI panel thinking about how we measure whether or not it works? how does this affect your thinking? And do you think this gives us permission to dismiss the argument that your interventions are not just assumed to benefit, therefore there is no equipoise, therefore there isn't the justification for randomization?
I think, certainly one of the measures in the new SIP model, seriously ill population model that CMS is launching sometime in April or May, days at home, and looking at patients who are protected from, as Jeff mentioned, those 10 hospital admissions followed by a subacute rehab visit and, not being at home. And so looking at that measure, of course, having a countermeasure of being alive and at home. So certainly looking at mortality to matched groups as well, but really keeping people healthy and at home and being accountable. I really liked what Jeff was talking about when you're care coordinating and doing those sorts of things, but it's to nowhere or to the abyss. What are we really doing here? And so how do we create an end-to-end model where there's accountability and responsiveness on Saturday or on Thursday night at 7 p.m.? And, one of the things I think we've seen with a lot of these telephonic case management models, or even these vendor programs, quite honestly, where there might be a lone NP in a state managing a population. What is our responsiveness at off hours, whether it's a medical model or something else? And how do we really hold ourselves accountable? So I do think one of these other measures, in addition to hospital admissions and so on, but really days at home, keeping people healthy and at home. And we'll test that measure. We'll see if that in fact is a right thing to look at.
The other thing I was thinking about while you were talking, Jeff, is just this idea that the randomized controlled trial that was developed for pharmaceuticals really doesn't fit, what we're trying to do. And yet there are ways that we can keep the rigor and yet adjust it to people instead of medications. And so, in different study reviews, thinking about practical clinical trials where you have an ability to adjust and do small tests of change and open up the intervention to the control group over time, as long as you have a funder that's willing to fund for that length of period of time. So, I think there are questions in the Q&A really around, how do we make the case to funders, and how do we do this in a way that establishes the evidence, yet doesn't kind of paint us in a corner in terms of, limiting complexity so much that we don't know what to make of it at the end of the day.
I think one of the other challenges we have in palliative care is now that it's really become standard of care in most hospital systems. It's really hard to know if you're trying to look and compare to a control group. You don't really know whether a control group has gotten palliative care. It's very difficult to pull out a claims data. So you kind of get that bleed in and you're not sure whether the control group has actually gotten the intervention as well. I think the other problem with some of the palliative care trials is a lot of it's just focused on decedent data. So it really tries to cherry pick a certain portion of the population that's entering that trial, which is obviously the most costly part of that, and it's usually limited to the last few months of life.
The one thing, a couple questions about, this population, and certainly being very different than most of our home palliative care programs, mine included, where we certainly exclude homelessness. We exclude people whose primary issue is substance use disorder. And so, here, Jeff, you're taking this sort of head on and not excluding the hard patients. And so I'm just wondering, as we think about, this population and we think about palliative care patients, how do you think about the models we design for different kinds of patient groups?
I think we need mainstream programs that do exclude these patients until they become patients that have problems that are well understood. So we need two different models. We need these models of evidence-based that are mainstream with lots of patients in them where the gears are running very quickly. And then we need models over here that are experimental, where we figure out how to deal with all these subsegments of outliers. Once you figure that out, you move that patient population over into the mainstream model. It's possible to do randomization, which just delayed care by 2 weeks or 4 weeks. So I think there's lots of ways, we'll never have enough staff to touch everyone who needs to be touched. And we've got to come up with much quicker ways. The other piece is that we don't understand regression to the mean very well. It's a very nonlinear phenomenon. It's not a statistical phenomenon, it's a clinical phenomenon. And for reasons we don't understand, certain people spontaneously improve. we've got a ton of work to figure out why, who gets better and who doesn't, and then turn that into a variable we can use for propensity scoring. So you could take a trial like Camden's or other RCTs and match it up with an artificial propensity scoring and train the model so that in the future you could have tables or you could have tools that very quickly give you some sense of whether something's working. One of the hard things about regression to the mean we found out is that if you do a national analysis of regression to the mean across the whole country using the Medicaid data set, you will find state by state, city by city, for the same group of patients clinically, a different regression to the mean. So it's actually a phenomenon that is not only in some intrinsic characteristics about the patients, but it's also some intrinsic characteristics about the community, about the delivery system, and about the level of social service resources. That's how complex regression to the mean is.
So we are at the top of the hour. So I just wanted to say on behalf of this esteemed panel, thank you so much, Jeff, for taking time to share your lessons learned and just for being such an incredible innovator and a contributor to the medical community. I feel we're so lucky to have people like you that are willing to not just do the hard work, but to share the hard lessons. And we appreciate it. And I'll just remind folks that the podcast version and the video version will be on the website, and we'll send out emails. We'll send out links that you've asked for that Jeff had mentioned. Again, thank you, Jeff, and thank you, Drs. Lustbader, Twaddle, Kelley, Brennan, and Bull for spending some of your time helping others learn.
Pleasure. Nice to be with you.
Thank you.
This has been great. Wish we could talk for hours.
All right, goodbye, everybody.